All right, everyone. Welcome back to all my listeners. This is season 15 in episode 12. Today is Wednesday, July 23rd, 2025. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, you guys, I hope you guys have been enjoying a really wonderful week out there. It is the third week of July here. The month is quickly coming to an end. I can't believe summer is almost over, right? So I hope you guys are still planning for all of those last-second vacations before the summer ends, right? And fall season is going to be ramping up with brand new things on all of our agendas. So I hope everyone is doing really, really well. All right, you guys. So today's Newsworthy is going to be featuring what's going on for the calendar year 2026 proposed rule. I feel like I just did this last year, right? When all of these proposed rules come out. And every year they are so interesting for those of us in the industry to read through and digest. So I'm going to be specifically talking about some highlights from the Medicare Physician Fee Schedule, the MPFS. And then, of course, in my Trusty tip, I'm going to focus on a very small PSA as a patient myself. I'm a patient advocate for sure. I wanted to go over a few claim error codes for my audience. And then, of course, I'm going to go ahead and close out and round out today's episode with another remarkable quote on hope and aspirations from Jonas Salk. All right, you guys, let's get into it. So in today's Newsworthy, I wanted to go over the fact that CMS issued several fantastic press releases last week regarding their proposed rule for calendar year 2026. Now, some main points included in a wonderful press release was that CMS is proposing the physician payment rule to significantly cut spending waste. They're also proposing to enhance quality measures. And they're also trying to improve chronic disease management for people with Medicare. Now, the press release states, quote, the calendar year 2026 Medicare Physician Fee Schedule, the PFS, proposed rule would advance primary care management through new quality measures, reduce waste and unnecessary use of skin substitutes, and introduce a new payment model focused on improving care for chronic disease management, end quote. Now, it continues on for reducing Medicare spending waste for skin substitutes. I really wanted to highlight that because I believe my audience has a lot of interest in this space. And it says, quote, Medicare spending on skin substitutes has had unprecedented growth, rising from $256 million in 2019 to over $10 billion in 2024, according to Medicare Part B claims data. Now, this dramatic spending increase is largely attributed to abusive pricing practices in the sector, including the use of products with limited evidence of clinical value. In one notable case, the CMS Fraud Defense Operations Center stopped more than $1 million in improper payments for skin substitutes to a medical group practice. The practice was submitting Medicare claims for wound care services allegedly performed by the owner, a psychiatrist. Now, CMS currently treats skin substitutes as biologicals for the purposes of Medicare payment, which can reach as high as $2,000 per square inch. CMS is proposing to pay for skin substitutes as incident to supplies, a change expected to reduce spending on these products by nearly 90%. These proposed savings would not come at the expense of patient access or quality of care. If finalized, this will save billions for Medicare and taxpayers and incentivize the use of products with the most clinical evidence of success, end quote. Moving on, the press release indulges us with shifting the healthcare paradigm to prevention and wellness. Quote, CMS is proposing to improve the care of chronic diseases by reducing burdens associated with the integration of behavioral health treatment into advanced primary care management. Additionally, CMS is proposing to make Americans healthier by removing 10 quality measures that did not directly improve patient health outcomes and adding 5 new outcome measures that focus on the prevention of chronic disease, including pre-screening for diabetes. If the proposed rule is finalized, a change to the Medicare Diabetes Prevention Program will allow more people with Medicare to access coaching, peer support, and practical training in dietary change, physical activity, and behavior change strategies to delay or prevent the onset of type 2 diabetes for people with prediabetes at no cost to the beneficiary. CMS is also issuing a request for information and RFI to gather recommendations on improving wellness prevention and chronic disease management. This includes input on nutrition counseling and physical activity, end quote. Now, the fact sheet on the proposed rule, which is CMS-1832P, has a great nod to telehealth services. And of course, I've been talking about that on the podcast for quite some time. Now, it says, quote, telehealth services under the PFS, the physician fee schedule. For calendar year 2026, we are proposing to streamline the process for adding services to the Medicare telehealth services list. We are proposing to simplify our review process by removing the distinction between provisional and permanent services and limiting our review on whether the service can be furnished using an interactive two-way audio-video telecommunications system. We are proposing to permanently remove frequency limitations for subsequent inpatient visits, subsequent nursing facility visits, and critical care consultations. We are also proposing for services that are required to be performed under the direct supervision of a physician or other supervising practitioner to permanently adopt a definition of direct supervision that allows the physician or supervising practitioner to provide such supervision through real-time audio and visual interactive telecommunications, excluding audio only. Except for services that have a global surgery indicator of 10 days or 90 days, we are proposing that a physician or other supervising practitioner may provide such virtual direct supervision for applicable Incident 2 services under Section 410.26, diagnostic tests under Section 410.32, pulmonary rehabilitation services under Section 410.47, cardiac rehabilitation and intensive cardiac rehabilitation services under Section 410.49. We are also seeking additional information regarding potential concerns about patient safety and quality of care for services that have a 0 global surgery indicator, and if it is necessary to exclude these services from allowing the presence of the physician or other practitioner to include virtual presence through audio, video, real-time communications technology, excluding audio only. We are not proposing to extend our current policy to allow teaching physicians to have a virtual presence for purposes of billing for services furnished involving residents in all teaching settings through December 31st, 2025. Rather, we are proposing a transition back to our pre-PHE policy, which requires that for services provided within metropolitan statistical areas, MSAs, teaching physicians must maintain physical presence during critical portions of the resident furnished services to qualify for Medicare payment. We would maintain the rural exception established in calendar year 2021, PFS, final rule, metropolitan statistical area, end quote. So I really wanted to go over some of those points for my audience. There is so much more to the calendar year 2026 proposed rule. There are a whopping 1,803 PDF pages. So make sure to read through as much of it as you possibly can and submit your comments, because the 60-day comment period for the calendar year 2026 PFS proposed rule, again, that's CMS-1832P, that 60-day comment period ends on September 12th, 2025. And now it's time for my best practice tips in Trusty Tip. Now, National Government Services, or NGS, has published their list of top claim errors. This is very, very useful, in my opinion, to my audience when they receive those EOBs or EOPs, those explanations of payments or lack thereof from their insurance carriers after they've received a healthcare service, right? So all of those receipts that you receive from your physician practice, those are called explanation of benefits or explanation of payment. And some of those codes on there are very confusing. So I wanted to go over the top 5 claim code errors for this region. Again, that's Illinois, the Midwest here for NGS. Now, there is the first one is for CO-22. Now, this error type is a straight denial, and it means that this care may be covered by another payer per coordination of benefits. Now, NGS has a tip here of how to avoid or correct this error. So they recommend that during patient registration, it's important for your office staff to identify whether a beneficiary's claims should be covered by other insurance before or in addition to Medicare. And I know I've gone over this in the podcast several times in regards to, I always recommend that the patient open up their pocketbooks, right, and lay out their insurance cards. And it is up to registration at the front desk to identify which of those insurance carrier cards is going to be a primary insurer, secondary insurer, or even tertiary insurer. So that is what that CO-22 code error on claims refers to, is that this care may be covered by another payer per coordination of benefits. Now, the second top claim error for this NGS region is for the code A55. Now, this is one that I have not really seen, but this is good for my audience to know, again, specifically for this region for NGS. So A55 is error type rejection. So it's not a claim denial straight up, which means the claim has gone through, right? This is a rejection. So the claim service lacks information or has submission billing errors. The usage for it is do not use this code for claims attachments with other documentation. So that is what that error definition is going to state on your explanation of benefits, right? There's also going to be a linkage to another code on that EOB. It's going to be a remark code for N245, which again is going to explain the fact that it is incomplete and invalid plan information for other insurance. Now, what does NGS say about their pro tip, right, for avoiding or correcting this error, this A55? So for your Medicare secondary payer, your MSP claims, they must include the primary insurance carrier's payment information, plan details, and subscriber information, because incomplete or inaccurate entries will result in claim rejection completely. So that means that claim won't even go anywhere. It is a straight up rejection. All right, let's move on to the third top claim error for this region of NGS. Now it is CO-16, so CO-16. Now this error type is a denial, and it's going to explain on that EOB that it is for a claim/service lacks information or has submission billing errors. There's also going to be a linkage to a remark code M51, which is for missing, incomplete, invalid procedure code. So at least that gives you a little bit more information. Now, NGS's pro tip for avoiding or correcting this type of error, again, CO-16. This denial message is specific, again, here in the NGS region, specific to things like chiropractic claims with CPT or HCPCS codes that are not billable by Medicare enrolled chiropractors. So Medicare Part B coverage for chiropractic care is limited to spinal manipulations billed with CPT codes 98940, 98941, 98942, and 98943. So I thought that was a really great example that NGS provided here for this type of error code CO-16. All right, then we can move on to the fourth top claim error code for NGS, and that is also CO-16, but this error type is for a straight up rejection. Now that explanation on your EOBs when it comes in is going to say that the claim/service lacks information or has submission billing errors. but it is linked to remark code N382, where it stresses that there is missing, incomplete, or invalid patient identifiers. Now, NGS provides us with their pro tip on how to avoid or correct this error, C016. But again, this error type is the one that is a straight up rejection. Now, they say that this error, the Medicare beneficiary identifier number, that MBI number, is necessary for all claims submitted to the MAC, right? That code, that number, that MBI number for each and every patient identifies the patient to the Medicare system, to the MAC, right? So that MBI is necessary for all claims submitted to a MAC. Claims without a correct MBI are rejected, requiring providers to verify and resubmit them. So that's really, really great information. And then finally, the last or fifth top 5 claim error for NGS is again another CO16. And this error type is also a straight up rejection. And it is explained further on the EOB that it is for a claim service that lacks information or has submission billing errors, but it is linked to a remark code N822, and that is specifically for a missing procedure modifier or modifiers. Now, NGS goes over their pro tip for how to avoid or correct this type of error. And they say that this rejection is the result of submitting a CPT or HCPCS code without a required modifier. You are required to research the proper modifier to report with the CPT or HCPCS code, and then you may submit a new claim. So I thought this was really great information. There are many, many more top claim errors that NGS has just published. So take the time and review. Your individual MAC could also be providing that type of really useful information to the practice. I also found this information really helpful to my audience, which also includes patients, right? I'm a patient as well. And when I receive those types of EOBs, because I'm in the industry, I know how to read them, but I also work with plenty of patients. I'm a patient advocate. I work with plenty of patients to help them understand what their EOBs are actually saying and what it means. So I hope you guys found this particular segment of Trusty Tip to be very useful. And finally, I focus Season 15 Spark on hopes and aspirations. I want this 15th season Spark to be filled with our world's thought leaders, writers, artists, philosophers, everyone who inspires us with their statements involving hopes and aspirations. So, in this week's inspiring quote in Spark is from Jonas Salk. Hope lies in dreams, in imagination, and in the courage of those who dare to make dreams into reality. Absolutely true, right? This quote reminds us to think about what hope can do. It can hold our thoughts and dreams. This quote encourages us to look at those that came before us, those with grit and those with tenacity, to see all they accomplished with their hopes and dreams. This quote reminds us to keep aspiring for more. I'm happy Jonas Salk's spark still burns brightly and can still inspire so very many. All right, you guys, that wraps up today's short and sweet episode. I hope you guys got a lot out of it. I hope you're going to spend some time digesting those 1,800 PDF pages when you get a chance. So then you can submit your public comments. We do have the right to impact change in healthcare here in the US. So absolutely take the time and do that reading. I always do from year to year. I find it really, really helpful to be in this industry and stay current and up to date. So anyways, you guys, I hope you are looking forward to whatever you have planned this weekend. Hopefully some lake time, some ocean time, get your toes in the sand, play some beach volleyball, whatever you need to do to get out into nature and decompress, get away from the work week and just enjoy your life. So anyways, you guys, thank you so much for listening on today's episode. And I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.